Welcome to the Rural American Surgeon. I'm your host, Dr. Randy Lehman. On this show, you'll receive powerful insights and resources for rural surgeons. I'm a general surgeon in Northwest Indiana, and this show is tailored around the nuts and bolts of rural general surgery practice. But you'll find topics ranging from practical surgical tips to a host of others, including rural lifestyle, finance, training, practice models, and more. We'll have a segment called Classic Rural Surgery Stories, where you'll get a feel for how practice in the country differs from the city. Whether you're a surgeon, other specialist, or primary care, or simply someone interested in healthcare for rural America, I'm glad you're here. Now let's get into the show. Welcome back to another episode of the Rural American Surgeon. I'm here with Dr. Chris Huiras, general surgeon from La Crosse, Wisconsin. Was very instrumental in training me, and I'm so glad that you came today. So thanks for joining us.
Thank you very much, Dr. Lehman, for the invitation. It's always a pleasure.
We're going to start with an introduction about you. So you can tell us maybe a little bit about your training, where you're from, and then what your practice looked like through the years.
Sure. My family is from Minnesota, but we moved to Madison, Wisconsin when I was young, which is where I went to high school, college, and medical school. And I did some of my residency training there as well. But I came to La Crosse, Wisconsin initially to do family medicine residency. I loved surgery, but I also loved peds. I loved OB. The spectrum of family medicine really appealed to me. But surgery got the best of me during my training in family medicine. I did my first year of family medicine training and really got bit by the surgery bug, primarily because one of the junior staff that just joined the practice and I got to be good friends. My friend, Dr. Gordy, came from St. Paul and came at the same time that I started my residency. And we hit it off. I think he must have really enjoyed being with house staff and anybody that, as opposed to being a young staff member and trying to relate to the old farts that were on the surgical staff at the time. But we got to be good friends, and he would invite me to help him on surgical cases as an assistant, even when I wasn't on a surgical rotation. And after the first year, I really got bit by the bug of surgery. It really made me happiest. I was most relaxed and happiest and energized when I was on surgical rotation. So I wrote away to some surgery residencies, actually thinking about changing specialties. I lived in La Crosse, Wisconsin. My last name looks foreign, and I got responses from a few programs saying we have more than enough qualified U.S. grads, so we don't accept foreign medical graduates. So I shelved it for a year, but in the course of the next year, Dr. Cusick and I spent a lot of time together, and it really burned inside me. So I applied for residencies, and I started my application process by applying to the Gunderson Clinic, who had a small program at the time and a limited number of residents per year. And it was the timing was really uncanny, probably supernatural. I interviewed for the residency on a Friday, and on Sunday, one of the first years was up all night on call at the hospital all night, and then Monday called up and quit. So I had just interviewed, and they offered me a position, and so I had the world's longest internship, 2 years of family medicine training, which I think really taught me a lot of basic medicine, and then 5 years in residency. And during my training, the local M&M conferences, staff conferences, etc. Gordy and the other partners would come and watch, and Gordy asked me to come back and join him in practice at the beginning of my fourth year, which was a real treat for me. It was a real honor. And then, so I completed my training, joined Dr. Cusick and the rest of the group at the other hospital in La Crosse. Unfortunately, Gordy, a few years later, developed stage 4 colon cancer in his 40s. No family history or anything, and it was a very traumatic time to lose a friend. But he was truly my inspiration. Taught me a lot. Was a friend, a colleague, a neighbor, and he had a no nonsense approach about him as a surgeon, but was gentle. He could communicate with anybody from the Mayo Board of Governors all the way down to holding my brand new baby's son. So it was, and his wife and daughters are darling people and lovely people. I miss him. I think about him often. And I have to say that he was the final pathway in drawing me back into a career in surgery. I have just spent over 30 years at Mayo, and Dr. Lehman, among others, have been rotating with us, rotating as a resident. And it reminds me how energized it can be to try to watch the next generation learn, ask questions about why you do what you do. And that's inspirational to me as well.
Yeah. Well, thank you. So, and then in your practice at La Crosse, that's a referral center of its own.
Correct.
Then you've also had some practice out in the critical access setting through the Mayo Clinic health system. And so you have this unique perspective. The next segment is the question, why is rural surgery important to you? But I maybe would like to say a quote from Dr. Cusick, which has been told to me, and I've told it dozens of times to other people. And that's in surgery, you can do C-sections or carotids, but not both. That sort of is a classic example of the spectrum of, you could do full spectrum general surgery, which may include vascular. Some people may be doing Whipples, they may be doing liver resections, esophagectomies. That would be like the highest level general surgery type stuff. Or you have this other practice, which is a rural practice where maybe you're doing scopes, you're doing some GYN stuff, hysterectomy, maybe you're doing tubal ligation, maybe you're doing vasectomies, like I do carpal tunnels. Maybe you're in a place where you do C-sections. So that's actually outside of general surgery. But then, of course, then you're not in a place where maybe you don't have an ICU anymore. So you're not doing the carotids and you're not doing the Whipples, So talk a little bit more about those two places that you've practiced and how it's been for you.
You bet. First of all, I would say my training program emphasized training for rural practice. We had experience in ENT, GYN, urology. We had to take orthopedics call. So the program started originally to train surgeons for more of a rural practice. It also prepared, very well prepared adequately for other specialty training. Some of my colleagues went on to do colorectal or cardiac surgery. But our residency training actually exposed us to a broad spectrum of the kind of surgery that you're describing. Interestingly, we were a referral center, but we also sent patients on. And we, during the course of my practice, we partnered with the Mayo Clinic and became part of the Mayo Clinic health system. That was a nice addition to what we had available to offer, because when I started, as most general surgery residents complete, it's bring on the Whipples, bring on the esophagectomies, let me do a lung resection. And that was a part of our practice for the first 10 years or so of my practice. But as the subspecialties evolved, and as the diagnostics changed as well, for example, endoscopic ultrasound for staging an esophageal cancer or pancreatic cancer, we didn't have that available. So we'd lean on the diagnostics in Rochester, and then the patients wouldn't always come back to see us for their surgery. Contrast that with our need to support two rural hospitals in western Wisconsin. We had clinics in both Tomah, Wisconsin and Sparta, Wisconsin, and had one surgeon covering both those locations. And in the early 2000s, at the time of the Gulf War, the surgeon actually was a reservist and was called up just after our place signed a contract with the VA system to provide colonoscopy. Well, now we had a contract and no surgeon to service it. And our department, our leadership asked, since I had an interest in endoscopy, if I'd be willing to cover that. And I jumped at the chance. I had always tried to make endoscopy a part of my practice, pre-op hernias, post-op colon resections, et cetera. So this was a natural extension of what I was interested in and capable of doing. And it is a different world. It's a 26-mile trip, but it's like 150 miles. And the county that it's in is much poorer than the average county in Wisconsin. So the patient population had fewer resources. Many of them were not as sophisticated about their own health care or neglected it. Some of them didn't have transportation to get to the big city of La Crosse and would actually walk to their hospital appointments or their procedures. I have to say that the opportunity to provide personal care and to make a huge difference in their lives because of their limited resources was a big part of the satisfaction for me in the rural practice.
Yeah. I think I'm nodding my head because I can relate with a lot of those things.
Yeah.
Let's move on to the next segment of our show, which is called How I Do It. And this time we're going to talk about open right colectomy. So first off, why would you want to do a right colectomy for someone?
For the general population, a right colon operation is typically done for tumor or cancer. In the world of endoscopy, frequently there are polyps that aren't able to be removed or would have threatening pathology, even if they weren't a frank cancer or cancer. It's primarily for neoplasms.
So it's mostly cancer. You're looking for your lymph node harvest. And
Correct.
So you bring the patient to the operating room, general anesthesia, supine position. Do you tuck the arms?
I tuck both arms.
Tuck both arms. And do you do anything else pre-anesthesia or before the operating room?
Patients have a Foley catheter. They have SCDs or thromboguards or whatever you call them. But for a right colon, you don't generally have to get into the pelvis. So plain supine position is perfect for it.
OG tube, NG tube?
I would leave that up to anesthesia. When I first started in training, every colon resection patient had an NG tube, and it stayed in until they passed flatus, 5 or 7 days post-op, and they sat in the hospital for that whole time. I quickly dispensed of that when I was in practice with myself, and I would make sure that anesthesia was satisfied with their NPO status, and if they needed to decompress the stomach, fine. But I don't put an NG in for a right colon.
So, okay. And then do you do any kind of special abdominal wall blocks or anything?
Well, as my practice evolved, the tap block really became a great tool, and it was either anesthesia or myself putting it in. But yeah, that's a wonderful.
Usually do those pre-op or post-op?
Post-op.
Okay.
Yeah.
Sounds good. I had, what was another question? Prep.
Standard abdominal. Well,
I'm talking about colon
before
prep.
surgery. Yeah. So that has taken a very interesting evolution. Used to be complete mechanical prep and 2 or 3 days of oral antibiotics taken hours apart that were not absorbed, neomycin, erythromycin, that would sometimes cause bellyache. We generally followed the colorectal literature about the evolution there. And toward the end, they would just get some laxatives and oral antibiotics the day before.
Yep. All right. So now we're basically prepped, we're draped widely, and you're ready to make your incision. So talk us through it.
Okay. I like small incisions. My hands are not tiny, but not gigantic. And I use magnification. I wear my loupes for virtually every open case. Part of that is as I aged and I needed reading glasses that made life easier, and you still look cool. But I would make a small incision, smaller than a hand port. I'd center it on the umbilicus. It depends on how long their torso is. You feel the rib cage and their ASIS, and I'd probably center it on that. I hate the keyhole incision where you make a jagged line around the umbilicus. So I'd make a gentle curve just to the right of the umbilicus, get through the fascia, and then find the omentum.
Okay. And then you chase the omentum down to the transverse colon and carry on.
Okay. I would actually do the majority of the operation using 2 Babcocks and 1 ligature device. I use the impact ligature that has a little curl on the end. It's a 10 millimeter device, and it's long enough to reach where you have to. So I'd find the omentum, and then depending on if I'm going to go to the right or the left of the middle calyx, I would divide the omentum down to the transverse colon. I'd enter the lesser sac, and I would work along the gastrohepatic omentum toward the gallbladder fossa. I'd enter there, and I would alternatingly place the Babcocks further along the colon as I freed it. I'd use my left-hand paw. My assistant hardly did anything for it other than hold a Richardson body wall retractor on the right side, and I always did these on the left side of the patient, so I could look down into their fossa up in the right upper quadrant, and I would just gradually worry my way down to the hepatic flexure. Hepatic flexure is avascular. I'd get it between my fingers, cut it with a ligature, and taking care to avoid the duodenum and the IVC. I would just gradually mobilize it, come along the white line at Tolt, down to the pelvic brim, divide the peritoneum overlying the pelvic brim just to get the TI a little bit freed up, taking care to avoid the iliac vessels and the ureter right there. And then I'd plop the whole mass on the abdominal wall and do an open transection.
So a couple questions.
Yes.
Number one, the incision that you made, you could get your hand in, right?
I could get most of my hand in, or I could get all of it in if it's a big patient. If it's a small patient with a mobile, like I remember an elderly nun who I made the incision and I almost pulled her whole colon up into the incision.
Sure.
It was like I made this too big.
So basically, when you're pawing with your left hand, you're just gripping and pulling it, and then doing your dissection.
I also splay out with my fingers, but yeah,
Okay.
I use that to expose, and then my right hand.
And then you said something about divide the omentum down. So did part of the omentum go with your specimen?
Correct.
Okay. So what I'm used to doing is pulling the omentum up and incising it right behind in that avascular plane, and then getting the colon down, leaving the whole omentum.
Yes.
So that's a little different way of doing it, but is there any particular benefit to one or the other? I can't really.
You could use if you left some momentum, you could stick it in your dead space that you left behind. But I liked it simply because if there was any question of tumor extension outside the colon, then I had the benefit of taking the extra tissue.
Gotcha. Especially in the transverse colon.
Correct.
With CCAM,
Yeah.
that maybe does.
Exactly.
But yeah, and I do the same thing. So with the omentum that I leave behind, then I put over the top of or at least wrap it. I don't necessarily stitch it around my anastomosis and things.
So if you divide it in the middle, there's plenty of
some
relief to put over your anastomosis.
Yeah, that's great. And then when you're come down the right white line of Tolt, you're using the impact for that too?
I use the impact or blunt dissection.
Okay.
In rare cases, I'll use a bovie on an extender because it's so thin and hardly any tissue.
Okay. Well, I guess from a Randy Lehman perspective, that answers all my questions.
I do have one other point to make, and that is I use the stapler to make a functional end-to-end anastomosis.
Yeah, up to that point.
Up to that point. I'm sorry.
Yeah.
Okay.
So anyway, go on with the anastomosis. Yeah.
And I will say that depending on the patient's BMI, body habitus, retroperitoneal fat level, one of the harder parts is actually trying to get the TI up enough to avoid irritating some of the tissue down behind the colon. So once I have it on the abdominal wall, then I choose my site of transection, and I will usually I try to be as efficient as I could, simply staying right on the bowel wall, and then some people will staple the specimen and then hand sew or staple off the defect. And I typically did this in 2 firings of the stapler, where I would select my site for transection. I would then create a rent in the TI mesentery and the transverse colon. There's a big avascular portion up here, but I would use the ligature to divide down to the right colic vessels. And then I would use 3 large Kellys. I'd clamp 2 on the patient side, 1 on the specimen side. I didn't suture ligate. I simply hand ligated with a heavy silk, O-silk usually, on the to make sure I had enough lymph tissue beyond the right colics. And then so I'd have the omentum and mesentery of the colon and TI all the way divided. Then I would change sides of the table. I'd create a rent big enough to take the individual side of the stapler, place the staplers in independently, connect them, fire it. So I would create my functional end-to-end anastomosis. I'd fire 1 more time across that to divide the specimen and seal the defect. The specimen's off the table. I didn't have any spill. I used 1 extra load of the stapler. And then I would change gloves, obviously. And then I would use figure of 8 vicryl sutures, usually 2 vicryl sutures to close the rent in the mesentery.
Okay. Any silks over the top of the anastomosis line anywhere?
Boy, that's the billion-dollar question, isn't it? I remember early in training, the stapler company representatives would say, "No, you don't have to suture or imbricate. You don't have to do any. You don't have to put a crotch stitch in. You don't have to do any of that." And I've done all of the above, and actually, I found if you're satisfied with the tension and the quality of the tissue, you don't have to do anything further. Your staple lines are secure without any reinforcement.
Okay. Well, maybe I need to get some guts then. But all I do is a crotch stitch. But but the other thing I do is I'm closing the common neurotomy with chromic and then silks over the top.
Sure.
But if you're doing basically the 2 staple load total technique, you have to use a pretty long stapler.
I use the 100.
100 blue load stapler? Okay. So 3.5 millimeter.
Yep. 3.5 millimeter stapler height or staple height.
Yeah.
Yeah.
All right. And there's a few other questions about your mesentery that I wanted to ask. So on the middle colic, sometimes I hold up and have backlighting and whatnot. Do you do any tricks like that to determine exactly where you're going to go on the middle colic?
I like to palpate for a pulse, and then I almost always could feel it. I do I have to say in Western Wisconsin, a lot of times you could not see through our patient's mesocolon. So that was a good tool in the proper patient. It was pretty rare for me to have to get a Doppler out to try to find a pulse for the middle colics. But generally it was by palpation alone and then making sure you're well away from either side.
So usually you're keeping that main middle colic,
Correct.
But it just depends. I mean, a mid-transverse thing, obviously you have to be extended, right?
The hepatic flexure was sort of my cutoff. If it was more proximal to the hepatic flexure, then I could do it. I'd do my resection to the right of the middle colics. If it was at the hepatic flexure or into the right transverse colon, then for a malignancy, I would definitely take the middle colics.
You take the middle colic and then basically still leave the splenic flexure up
in
that situation, and you would still be able to get your TI up there, close your mesenteric defect and all that.
Correct.
You always close your mesenteric defect.
Yes.
Because sometimes that can be quite the good-sized defect.
Yeah, and where I ran into problems with that more often was in a sigmoid resection or an extended, if you included both flexures. The mesentery of the small bowel is pretty easy to approximate to your cut edge on the colon side. And so I generally didn't have a problem bringing that up together. And so I liked not having a big internal hernia mechanism right there.
Right, yeah, sure.
Now, I also...
Go ahead.
Yeah? Okay.
Yeah.
I've seen a variety of ways of closing the mesenteric defect. A running suture seems like it might be more efficient, but if it's a thin patient with not a lot of integrity to the one side or the other on the leaf, you can end up tearing out, and then you got a banjo string, which is like worse than the soft tissue. So I typically would use interrupted figure of 8 sutures. So I'd get bulky enough. They'd be figure of 8s, so I wouldn't have to be tying 5 knots. And I could space them so that it would even take a little of the tension off the anastomosis.
Yeah, I could do how I do it with you all day long because there's so much thought that goes into every little thing. I really appreciate that. And I love talking to you. Like while we're doing the case, I would always ask these really, really detailed questions because I knew you'd have an answer. If I asked somebody else, they would just be like, hey, you're a resident, keep your mouth shut. But all right. So thank you for that. Anything else on the right colon?
No.
So, I mean, obviously we've really progressed in terms of our ARAS protocols and whatnot. And so then we're having, the last 3 right colectomies that I did within the last 6 weeks, all went home on post-op day 1.
Excellent.
I mean, it's just getting ridiculous, but
But I didn't mind making a smaller abdominal incision for specimen extraction. I know you can make a fan steel and get it out that way, but for me, this was the most efficient way of doing a right colectomy, and it was easily less than an hour, usually 25 to 30 minutes, depending on the patient's build.
Yeah, I guess I didn't ask fascia closure
I do a mass closure, PDS 2 lengths. That way, it's a small hole. That way, I can start at either end and tie it in the middle.
With a single strand or double strand?
I switched to double-stranded OPDS near the end of my career.
And then if they were fluffier and they had 4 centimeters of sub-Q, did you ever do sub-Q?
I did not.
Okay.
I was very meticulous about caring for the sub-Q after the fascia was closed, making sure hemostasis was perfect and copious irrigation. But the times I felt like I got into trouble is when I used Vicryls to close my sub-Q.
Okay. And so then what did you do with the skin?
I used monocryl virtually all.
Yeah, great. All right. Well, let's move on then. We could talk all day, I think, about that and other things, but at some point you have to just draw the line. So next part of the show is the financial corner.
All right.
So it's just somewhat of a personal passion of mine that I think everybody is on this financial journey, and the more that we can kind of have that under control, we don't have to worry about it, and we can have our mindset on the things that really matter. So if you have a tip for maybe a junior resident or a junior attending that would be a financial tip, the floor is yours.
I would say buy a smaller house than you think you can. You spend all this time in training, all the delayed gratification, you're getting all this adulation from the staff, from your family. You deserve a mansion. You deserve a giant house to live in. And yet, the realtors will sell you one, and all the recruiters will push one on you. But then you're a slave to your house, and you aren't flexible. You're worried if your practice starts out slow. It's like, how am I going to make these house payments? It gives you the opportunity to be more flexible with your time, but also your finances. If your entire salary is taken up in your debt service, then you can't respond to charity in the community or time off. To me, you're not a slave to your house.
You sound like you're speaking from experience.
Yes, sir.
Tell me more.
I got some excellent advice, actually from a college professor mentor that I knew from Bible study in college, and he said, "You're going to be offered an awful lot, but start out modest."
You managed to do it.
Yes, I did.
Okay, that's good.
Yep, and I still have the same house that I started out in.
Nice. Wow.
Yeah.
So I have 3 follow-up thoughts to that.
Okay.
First off is, if you've heard of Robert Kiyosaki, he's kind of a guru in the personal finance space.
Okay.
And one of his books, Rich Dad Poor Dad, which I think has changed a lot of people's lives. There's a lot of debate about it, but it's got good concepts. Talks about your house not being an asset. So, it is an asset. It's on your balance sheet. You own it. You could sell it. Obviously, it's an asset. But it's actually an asset under the bank's balance sheet.
Right.
And for you, your house is actually more of a liability, because what does it do? It costs you money every month. And so his argument is that an asset is something that makes you money every month and doesn't lose you money every month. The other thing is that the house, often people will say, is the best investment they ever made. But that's usually because it's the only investment they ever made. And the house, I guarantee you, compared to some investments that I've made, there's no house that's ever going to be as good of an investment as actual investments.
Correct. I would endorse that fully.
So there's that. And then the second thing is, I remember being I think I was an intern on plastics, and there was a chief plastics resident who, it was around Super Bowl time, and he just finished he was finishing residency. He just signed a new contract.
Okay.
And this was like when the curved TVs were becoming a thing. And we were sitting around this table doing morning rounds, and then he starts telling us this story about this huge curved plasma TV that he just bought that was like longer than me, and for his basement that basically he just signed his contract, and he's like already rewarding himself, hadn't done any work for it, and essentially bought this thing on 90 days, same as cash. And so many people spend their paycheck before they ever made it. And there's no reason. You just watch the game with your friends. It's not really about that. And then the last thing I'll tell a personal story about. So the first house that I bought in Winnemac, Indiana, it was, I called the bank because I had heard that there were these physician mortgages that you could put no money down, but at the same time not pay mortgage insurance, PMI.
Oh, yeah.
And so it's like, I'll check it out, And so I called them, and I already had a house picked out and under contract. And the guy said, "Oh yeah, absolutely. We'd love to lend up to $750,000, no money down, no PMI, and up to $1.5 million if you put 5% down, no PMI." I'm like, "Oh, okay, great. So then this $86,000 house that I bought that I have under contract should be no problem to you." And he said, "Well, actually, let's just hold on. We got to think about this here."
So jumbo mortgages.
Yeah. So then he says, "Well, actually, this was in February, and my job didn't start till January. So he's like, or July. So he's like, we only do this 3 years out from, 3 months out from when your start date is. So since it's not within 3 months of starting, then we can't actually qualify you for this." And I said, "Okay, that's no problem. You can just use my regular job working as a resident. My salary from that should still cover it." And he says, "Well, actually, since you told us that job's ending, we can no longer use your salary from that job." So like, okay. So then I just called up my regular banker who I already had bought a 12-unit apartment, and I was in the process of buying a large commercial property with. And I said, "Hey, you guys want to do? I'll put 20% down. I'll just buy the house and not worry about it." "Yeah, sounds good." It's why don't you even just have paid off grass under your feet too? That's another thing.
Yes.
But you got to think about every little piece of the math that it pertains to your scenario. But a lot of people are house broke, and the other problem is you buy the house, then you have to have the furniture that matches the house, the car that sits in the driveway. You pay the taxes, the insurance, the heating bill. It's not just your loan payment. Send your kids to the private school, country club.
It's rarely part of the equation when you're making that decision.
Yeah,
and that's very valid. It's really true.
So
it's really true.
You hit the nail on the head with the house, and you got me fired up. So that's good.
I can see that. Now let me ask you the follow-up question, because when interest rates were falling, I finagled a 2.5% loan, and all my other, I can pay off my mortgage, but I have about 2 years left on my mortgage, and I can deduct my mortgage interest, maybe, depending on my status that year. But my other investments are earning far more than that.
Right.
So while I still owe a little bit of money on my house, I don't.
Right.
So yeah, it allowed me to be that nimble, and I think we're of one mind about the starting out. So that is really good advice, and you can always upgrade, or you may find the housing market change if you don't like your job, or whatever. You're not stuck.
Yeah, you just give yourself so many more options by not getting yourself house.
Yeah.
Well, thank you for that. Let's move on to the next segment of the show that's called the classic rural surgery. So some story that has actually happened to you that is just classic rural surgery.
I can think of some people that represent the true poverty in Monroe County. People that couldn't afford the gas money to drive to La Crosse, 26 miles. They could see me in my clinic in Sparta, but if they had a follow-up or a test in La Crosse, they didn't have gas money to drive 26 miles round trip. I see that as part of my outreach mission. That was really part of the gratifying aspect of my practice, that way, to be able to bring high quality care to them.
Did you have anybody ever who you were trying to get them, in terms of that quality, you're trying to get them somewhere else because you believe that would be higher quality if you could do something somewhere else, but then they just couldn't get it done?
Mm-hmm.
And then do you have any
it was a lung cancer patient that needed an operation, and needed to cross into a different state. She needed to go to Rochester, Minnesota. And so it took months for her to even get a diagnostic test. I do have, there was one aspect of, I know that you mentioned it, there was a story. When I, on call one weekend, 2 weeks after opening of the deer season in Wisconsin, which is like a national holiday, an Amish family brought their son to the emergency room because when he was cutting up his deer the afternoon of the opening deer season, he followed through and stabbed himself in the thigh. And he had arterial bleeding at the time. The family put tourniquets on him, interestingly enough, and they also put ground red pepper, because apparently it's a coagulant. And 2 weeks later, he didn't get better. 2 weeks later, he started leaking out of his leg again. I thought he probably had an AV fistula. So I cared for him in the mothership in La Crosse, and explored his leg and repaired a muscle branch artery injury and got him. And about 2 months later, the dad called me. Now, Amish aren't typically able to use a telephone, but he has excellent neighbors. And he called me and said, my son cut his forehead open last night ice skating, and it was going to cost me $500 to go to the Black River Falls emergency room. Is this something you could do? And I said, meet me in the parking lot of the clinic, and I'll see him. So this was a Sunday morning. He called me about 10 a.m., and he came in, and his son had been on his friend's shoulders while they were ice skating. He fell off and cut his forehead open. So he had a big laceration that was more than a few hours old, but it was clean, and I was able to repair it. So I said, yeah, I can do this. And I prepped him, sewed it up, turned around, and his dad is standing there with an apple pie and a $50 bill in his hand.
Oh, wow.
And he said, word is starting to get out about you. Do you like these kinds of side jobs? And I said, well, I can't really do x-rays or get you medicines, but this kind of stuff is right up my alley. And then he said, how am I getting my pie plate back? I might never see you again. And I said, just a minute. And I went around the corner to the nurse's break room and found two plates and flipped it over and gave him his pie plate back. And he called me one other time about another injury one of his kids had. But I think that's a great story about being on the front lines with people in smaller towns.
That's classic rural surgery.
Yeah.
Great. So the last segment of the show, resources for the busy rural surgeon. So rural surgeons have a lot on their plate.
Yes.
Where do they need to go for quick answers?
That's a great question. If you're by yourself, I used UpToDate. Our institution subscribed to it, and excellent resources. And then I think you have to rely on your friends. So any colleagues or friends that you developed in training, or either the teachers or your residency classmates, I think having an opportunity to call somebody, having somebody in your back pocket to call with a question about that kind of stuff is invaluable.
Yeah, that's been a recurring theme. You also brought a book with you.
I did. I brought
it's a good shout
Surgical
out.
Clinics of North America. Tyler Hughes, Dr. Hughes, thank you very much for pioneering this. And one of my colleagues actually authored a chapter in here. And this is a great resource about many of the practical applications of performing rural surgery. Yeah.
Well, Dr. Huiras, thank you again so much for being on the show.
Thank you,
It's
Dr.
been an honor, and I just really appreciate everything you've done for me in my training. So, guys, thanks a lot for watching. Don't forget to like and subscribe. Tell all your friends if this has been helpful to you. We'll see you on the next episode of The Rural American Surgeon.